picture a chaotic trauma center.
Yeah.
Right? Like the fluorescent lights are buzzing, a massive team is scrubbing in.
Oh, yeah, adrenaline is just completely through the roof.
Exactly. And a paramedic radios ahead from the ambulance. They say something like, gunshot wound, posterior to the left nipple line at the 5th intercostal space.
And the wild thing is, before that patient even rolls through the double doors, the surgical team knows the exact trajectory of the bullet. I mean, they know exactly which lobes of the lung are compromised.
Right, they know how close the damage is to, say, the heart's left ventricle, and they know exactly which surgical instruments to have sterilized and waiting, all down to the millimeter.
It really is absolute precision because they rely on this invisible three-dimensional coordinate system that's just mapped onto the human body.
And that is exactly what we are getting into today. Welcome to our deep dive into the really high-stakes world of directional and positional medical terminology. We're looking at a huge stack of medical history and anatomy notes today to decode this standardized language.
Yeah, because we really want to move past, the basic flashcards of terms like anterior, posterior, medial, and lateral. We want to understand the hidden geometry of the body.
Right, and to see how this centuries-old grid was painstakingly negotiated. Because the whole mission here is to create a shared, unambiguous language for doctors operating anywhere from, Seoul to São Paulo.
To really understand that geometry, though, we have to start with the foundational 0 point. I mean, you can't navigate a physical space without a universally agreed-upon map or compass, right?
Right, like an origin point on a graph.
Exactly. In medicine, this is called the anatomical position. It dictates that every single positional term assumes a body standing upright, feet flat and facing forward, arms at the side.
And the hands, right. The palms had to be facing forward.
Yes, supinated, palms facing forward.
Which, that requirement for supinated palms is just mechanically bizarre to me. If you look at anyone waiting for a bus or just relaxing, nobody stands like that.
No, absolutely not. It looks like an action figure fresh out of the box.
Yeah. Their palms naturally face their thighs, like the hands naturally fall into this semi-pronated position. So why did the medical field deliberately choose such an awkward, unnatural posture for its ultimate 0 point?
Well, so that's actually misconception number 5 from our sources. Students constantly make this mistake. They assume the anatomical position is supposed to represent a natural resting state.
But it's not.
No, not at all. It is a highly artificial convention, and it was designed to solve a very specific structural problem regarding the forearm.
Okay, what kind of problem?
So when your arms hang naturally and your palms face your thighs, the two major bones of your forearm, the radius and the ulna, they actually cross over each other. They make this sort of X shape.
Oh, wow. I never really thought about that.
Yeah.
So the bones are literally twisting around each other.
Exactly. And if the baseline coordinate system allowed those bones to stay crossed, the entire spatial map of the arm would just completely collapse.
Oh, I see. Because the outside of the wrist would physically flip to become the inside, depending on how someone was holding their hand in the ER.
You nailed it. The lateral side becomes the medial side. It would be chaos. So by forcing the palms forward into that supinated stance, the radius and ulna are completely untwisted. They sit in perfectly parallel tracks.
So it locks the variables.
Precisely. Whenever a surgical note describes a lesion on the, say, medial aspect of the forearm, the surgeon implicitly measures that location against that rigid, palms forward stance. It completely ignores how the patient's arm might actually be positioned on the table at that moment.
Which brings us to, really, the core design feature of this entire linguistic system. The coordinates are locked to the body's internal geometry, not to the external gravity of the room.
Yes, the auto-rotate analogy. I love how you phrased this earlier.
Yeah, it's just like the auto-rotate feature on your smartphone.
Yeah.
Once you turn auto-rotate off, your phone's operating system registers up as the top bezel of the screen, completely independent of how you're holding the device in the real world.
Right. Gravity is completely irrelevant to the anatomical grid. If a patient is lying flat on their back, supine on an operating table, their head and their feet are at the exact same elevation relative to the floor.
Right, they're totally flat.
But the surgeon still documents the heart as superior, meaning toward the head to the stomach. The internal map just never shifts.
And looking at the heart actually provides this brilliant demonstration of this internal geometry. Because, we tend to think of the heart as this symmetrical, vertically aligned shape right in the dead center of the chest.
Like a Valentine.
Yeah, exactly, like a little cartoon heart. But structurally, it is actually a tilted cone, and it's rotated on its axis,
Yeah, the base of the heart, which is that wide superior portion where all the massive vessels like the aorta and vena cava attach, that actually sits posteriorly.
meaning it anchors toward the back, toward the spine.
Exactly. And the apex, that muscular pointed tip of the left ventricle, that projects anteriorly, inferiorly, and to the left.
So it essentially points down and forward into the front of the rib cage.
Right. And that tilted orientation dictates the entire physical exam. When a cardiologist assesses the point of maximum impulse, the apex beat,
Right, when they're listening to your chest.
yeah, they bypass the center of the sternum entirely. They palpate the anterior chest wall down near the fifth intercostal space on the far left side. They are physically intercepting the geometry of the organ.
You see the exact same spatial logic with the kidneys, too. Because they are retroperitoneal, meaning they sit behind the peritoneal cavity, roughly between the 12th thoracic and 3rd lumbar vertebrae.
Right, they're tucked way in the back.
Yeah, so a physician checking for pyelonephritis, or like kidney trauma, they don't press on the anterior abdomen, the front of the stomach. They percuss the posterior flank. They tap on your back.
Because the grid dictates the clinical approach. And, when we map the peripheral structures, the limbs, the spatial logic shifts away from the central cavity. It starts looking at the distance from the body's midline using medial and lateral coordinates.
Like the malleoli of the ankle. Right, that perfectly illustrates this.
Oh, perfect example. Yeah, every person has two bony prominences on each ankle joint. The bump that points toward the inside, toward the body's center line, is the medial malleolus.
Formed by the tibia.
Right. And the outer bump is the lateral malleolus, which is formed by the fibula.
So medial is toward the middle, lateral is toward the outside. But the coordinate system adapts again when mapping the length of the limbs, right? Relying heavily on proximal and distal designations.
Yes, proximal indicates it's closer to the trunk's attachment point, like your shoulder or hip, while distal is farther away, down the limb.
And these terms are highly specific to the appendicular skeleton, right?
Right.
The limbs. Like, you wouldn't describe your nose as distal to your ear.
No, you'd use anterior or posterior for that. But for the arms and legs, proximal and distal do tremendous heavy lifting in trauma medicine. Consider a Fuchs injury.
Fuchs. Full on outstretched hand, right?
Exactly. Someone trips, they put their hand out to catch themselves. The kinetic energy from that impact travels up through the carpal bones in the wrist, and it frequently shatters the radius.
Ouch. And the spatial designation of that fracture changes the entire surgical protocol.
Completely. A distal radius fracture occurs way down by the wrist joint. The surgeon might repair that with a specific volar plate and some screws.
But if it's proximal?
If it's a proximal radius fracture, that's all the way up near the elbow joint, it might involve the radial head. That requires a totally different surgical approach, distinct hardware, a totally different rehab timeline.
So just putting the word distal in the pre-op chart instantly disambiguates the mechanical failure before anyone even pulls up the x-rays.
Yes, it's incredibly efficient. But navigating the limbs also introduces this really fascinating embryological quirk. This is something students always trip up on regarding the terms dorsal, palmar, and plantar.
Oh yeah, the surface quirks. Because dorsal universally maps to the back of the trunk, like a dorsal fin on a shark.
Exactly. But on the limbs, the dorsal surface is the back of the hand, which makes sense, but it's also the top of the foot.
Wait, the top of the foot is dorsal?
Yep. And the gripping surfaces are distinct. Palmar for the palm of the hand and plantar for the bottom of the foot.
It seems so contradictory. Like, why wouldn't the top of the foot and the back of the hand face the same way? Until you look at human fetal development, right?
Right. Early in utero, our upper and lower limb buds actually point in the exact same direction, but as the fetus develops, the upper limbs rotate externally outward, and the lower limbs rotate internally.
So the coordinate system is actually tracking that ancient embryological rotation.
Exactly. The top of the foot and the back of the hand originate from the exact same developmental surface, so they share the dorsal designation, even though they face completely opposite directions in an adult standing upright.
That is wild, and, that kind of precision, it feels so clean and mathematically logical to us today. But we really have to emphasize that it represents the culmination of centuries of absolute chaos.
Oh, total chaos. The medical community spent over a millennium operating under a fundamentally flawed map of human coordinates.
The history here is staggering, particularly this 1,300-year blind spot stemming from Galen of Pergamon.
Yes, Galen, the undisputed gospel of early medicine. He was a Greco-Roman physician in the 2nd century CE. But the catch is, human dissection was strictly prohibited by Roman law at the time.
Right, it was taboo, so he couldn't actually look inside a human body.
Exactly. So Galen had to map the body by dissecting Barbary macaques, oxen, and sheep. And he just blindly extrapolated that animal geometry onto human.
He just assumed we were identical on the inside, which led to some spectacular errors in the literature.
To put it mildly, the most enduring mistake was his detailed description of something called the rate mirabile, which translates to the wonderful net.
A wonderful net. Sounds magical.
It's basically a highly complex vascular plexus, a net of blood vessels at the base of the brain that regulates temperature. Galen mapped its coordinates meticulously, and the rate mirabile is an incredibly important anatomical structure if you are a sheep.
Right. But humans do not have it. Our cerebral vascular supply relies on the circle of Willis, which functions entirely differently.
Completely differently, but because Galen's texts were protected by this intense institutional and religious dogma, literally no one dared to challenge his findings.
So medical students for over a millennium were explicitly taught the spatial coordinates of a sheep's brain network, thinking it was human anatomy.
For 1,300 years, let that sink in, the turning point didn't actually arrive until 1543.
Enter Andreas Vesalius.
Yes, a Flemish anatomist working at the University of Padua. And he just systematically dismantled Galen's legacy. Padua was unique because local judges occasionally granted Vesalius access to the cadavers of executed criminals.
And crucially, he did the dissecting himself, right? Because back then, the standard academic practice was for the professor to sit in this elevated chair just reading ancient texts out loud, while a lowly barber surgeon actually did the messy cutting down below.
Right, they weren't even looking at the body. But Vesalius actually descended to the table. He performed the dissections with his own hands. And he published this massive text, De Humani Corporis Fabrica, which completely rewrote the coordinates of the human body through direct observation.
He corrected over 200 of Galen's specific structural errors. It's actually kind of poetic that his atlas was published in 1543, which is the exact same year Copernicus published his heliocentric theory.
Oh, wow, I didn't realize that.
Yeah. So while Copernicus was remapping the coordinates of the solar system, Vesalius was remapping the inner space of the human form.
That's a brilliant parallel. But even though Vesalius established the necessity of a standardized reference frame, the vocabulary itself was still a completely chaotic wilderness.
Right, because everybody was just naming things whatever they wanted.
Exactly. By the late 19th century, with rapid advancements in global research, there was just massive redundancy. A single anatomical structure could easily possess 6 completely different names, depending on whether a physician trained in, Paris, Berlin, or London.
And a global medical profession just cannot function with tens of thousands of competing geographical terms. So in 1895, the German Anatomical Society organized this massive summit in Basel, Switzerland, to initiate the ultimate editing job.
And thank goodness they did. The resulting Basel Nomina Anatomica ruthlessly slashed the bloated lexicon down to roughly 5,500 highly standardized terms.
Just a brutal editing process.
Yeah, and that framework evolved into the Terminologia Anatomica that we use today, universally governing over 7,500 anatomical structures.
So that standardization brought order to human medicine, finally. But as our sources point out, it actually triggered a fierce, ongoing debate within the broader biological sciences.
Right, the animal problem.
Yeah, because the Terminologia Anatomica was built explicitly for a bipedal human. And standing upright completely shatters the universal grid used for literally every other vertebrate species on Earth.
It really is an evolutionary glitch. Think about a quadruped, like a dog or a horse. Their body's primary long axis runs horizontally, parallel to the ground, so the spatial terms align perfectly with their movement.
Right, cranial points toward the head, caudal points toward the tail, dorsal maps the spine, and ventral maps the belly.
Exactly. So if dog walks forward, its cranial end leads the way. But when human ancestors stood up on 2 legs, our long axis rotated 90 degrees to become vertical.
So if we strictly apply the terms anterior, meaning front, and posterior, meaning back, we run into a massive biological contradiction.
Huge contradiction. Because for a fish or a dog, anterior is essentially synonymous with cranial. It's the front of the moving animal. But because humans rotated vertical, our anterior actually points toward our belly.
We totally decoupled our anatomical front from our leading edge of motion. And comparative anatomists, the scientists who study structures across multiple species, They strongly advocate for universally abandoning anterior and posterior altogether.
Right. They want everyone to just use the posture-independent terms, ventral and dorsal. Ventral always means the belly surface, whether that belly is dragging on the ocean floor or, sitting in a boardroom chair.
So why don't we? If ventral and dorsal work for all vertebrates, why do human doctors still cling to anterior and posterior?
Well, international anatomical committees debate this all the time, but the resistance from human physicians is entirely rooted in clinical continuity.
Legacy data.
Exactly. Millennia of medical charts, surgical notes, diagnostic imaging, it all relies heavily on anterior and posterior, forcing every hospital on Earth to suddenly flip their vocabulary to ventral and dorsal would introduce a staggering risk of misinterpretation.
Especially during that transitional period. Changing the coordinates mid-flight is incredibly dangerous. So the medical establishment essentially prioritizes the safety of legacy data over strict evolutionary accuracy.
Mostly, yes, but there is actually one specialized field of human medicine where the bipedal grid just completely breaks down and it forces physicians to adopt the animal terminology.
All right, neuroanatomy,
Yes, the embryonic cephalic flexure basically ruins the standard grid,
the brain bend.
the brain bend. During early fetal development, the human neural tube undergoes this dramatic structural deformation. The forebrain physically bends forward over the brainstem at roughly an 80-degree angle.
It functions mechanically like a kink in a garden hose.
That's a great way to picture it, and because of that sharp angle, the geometric axes of the brainstem and the cerebrum no longer run parallel. They're bent.
So if a neurosurgeon relies on the word anterior, it becomes dangerously ambiguous. Does anterior point toward the front of the patient's face, or does it point perpendicular to the spinal column?
Exactly. The flexure causes those coordinates to intersect rather than align. So to circumvent the kink, neuroanatomists utilize rostral, meaning toward the nose or beak, and caudal, meaning toward the tail end.
So they switch to the dog terms.
They do, because these terms follow the physical curve of the neural tissue itself. It preserves the spatial logic of the central nervous system regardless of how severely the tissue folded during development.
Which is brilliant.
Yeah.
And, this tension between historical legacy, biological reality, and clinical practice, it really ultimately returns us to the physical reality of the operating room.
Yeah, back to the trauma center we started with.
Exactly. Because this linguistic rigidity, all these strict rules, they're entirely designed to prevent catastrophic failures. The kind categorized by the Joint Commission as never events.
Never events. Just the name tells you how serious they are. These are unambiguously disastrous medical errors. We're talking about operating on the wrong organ, performing a procedure on the incorrect limb, or leaving surgical instruments inside a patient's body cavity.
And using casual language directly fuels those never events. If a preoperative note just says, make an incision on the front, or request a procedure on that side, the ambiguity completely invites interpretation.
It really does. Like, a surgical team might easily confuse an anterior approach to the cervical spine, which means going through the front of the neck with a posterior approach. And making that mistake risks catastrophic nerve damage.
The spatial vocabulary mitigates that risk by operating almost like mathematical code. We see this really clearly with neurological evaluations utilizing the terms ipsilateral, meaning the same side, and contralateral, meaning the opposite side.
Right. Because the descending motor pathways in the human nervous system cross over to the opposite side of the body at the base of the medulla in the brainstem. It's a structural crossing known as the decussation of pyramids.
So because of that crossover, a neurologist viewing an ischemic stroke in the right motor cortex inherently knows the patient's physical paralysis will manifest on the contralateral side, the left side of the body.
Exactly. So simply charting contralateral hemiparesis instantly communicates the exact geometry of the neurological deficit. There's no room for guessing, wait, which side did he mean?
And if those terms aren't deployed with absolute rigor, an entire cascade of clinical errors can easily follow. But the medical field realized that linguistic standardization just wasn't enough on its own. They had to mandate its use procedurally.
Hence the universal protocol. Hospitals worldwide operate under this. It mandates strict surgical timeouts.
What does that look like in practice?
So, before a scalpel ever touches skin, the entire surgical team ceases all activity. Everything stops. They verbally cross-reference the patient's identity, the specific procedure, and the precise anatomical site. And they communicate exclusively through this unambiguous Latin and Greek vocabulary.
So they verify physical site markings on the body against the rigid coordinates in the chart. They are methodically stripping away the fatal ambiguity of conversational English.
That's exactly it. Conversation is too messy for the OR.
Wow, we have mapped an incredible journey today. I mean, we started with an awkward, artificially supinated 0 point designed to uncross the bones of the arm.
Yep, palms forward.
We navigated the 1,300-year blind spot of a sheep's vascular net, observed the surgical theaters of Padua, and watched international committees violently edit thousands of chaotic terms down to a unified, life-saving grid. Anterior, distal, rostral, contralateral, they form a highly engineered three-dimensional matrix hovering just beneath the skin.
And you know, the terminology really represents an astonishing linguistic achievement, but it's built explicitly around our specific upright evolutionary posture. It maps the bipedal human as we exist today.
Right now, yeah.
Which leaves me with a final thought to mull over. It is really intriguing to consider how resilient this 1895 coordinate system truly is in the face of our ongoing physical evolution.
Oh, meaning transhumanism.
Exactly.
Yeah.
If medical science continues its rapid integration with biomechanical modifications, think about cybernetic prosthetics that fundamentally alter our primary axis of movement, or exoskeletons that introduce entirely new ranges of motion. The geometry of the human form is going to change.
That's a wild thought.
If we physically transition away from a standard biological biped, we might eventually have to convene a brand new global council to redraw the coordinates of the human body all over again.
We need a completely new Vesalius for a transhumanist age. But, until the geometry of the human body changes, that invisible grid holds firm. So the next time a paramedic calls in a trauma trajectory or a neurologist maps a stroke, you understand the centuries of observation, correction, and immense physical stakes that guide their hands with absolute precision. That's all for today's deep dive.